Hi, everybody. Okay, so this is part two of our lecture series for disorders of the hematopoietic system. So this is essentially going to cover chapter 21 in this section. So we're going to start with anemias, and we're going to talk about some specific disorders that are associated with the hematopoietic system. So let's talk about what anemia is and how they're classified. So essentially an anemia is, as you can see here, a reduction in the number of erythrocytes in the circulating blood, or it can be in the quality or quantity of hemoglobin. It can be a combination of things. So essentially what we have when we have an anemia is an impaired erythrocyte production. Acute or chronic blood loss can be a cause. We can have increased erythrocyte destruction. We'll talk about what that looks like, and or we can have a combination of all of the above. So they are typically classified by their causes. For example, there is such a thing as anemia of chronic disease, or by changes that affect the size, the shape, or the substance of the erythrocyte. So the most common classification of anemias is based on changes that affect the cell's size and the hemoglobin content. So we're going to focus on that. And there's some terms that help us to identify that. So when we look at how we classify anemias, we want to keep in mind the terms ending in cytic. You can see over here on the right-hand side, because that is directly related to size. If you see normocytic, microcytic, macrocytic, that's going to be indicative of the size of the cells. If you see chromic as a suffix on the word, we're talking about hemoglobin content of the cell. So the etiology of anemia refers to what caused it to happen. So again, those are those things from the first slide that we talked about. So that's an impaired ability to produce erythrocytes. It can be related directly to blood loss. So you've actually just lost erythrocytes. It can be increased destruction of those red blood cells or a combination. So when we look at the term morphology, we're looking at what is going on. So again, if there's a problem with the size, the suffix of the word will be cytic, and you can see they're macrocytic. So that means large-sized erythrocyte. Microcytic is referring to a small-sized cell, and normocytic means it's a normal-sized cell. The same thing for hemoglobin content, ends in chromic. So if it says normal chromic, it means it has a normal hemoglobin content. And if it's described as hypochromic, it has a low hemoglobin content to that cell. And then I just wanted to familiarize you with a couple of vocabulary words. So the anisocytosis refers to red cells that are present in various sizes, because normally they should be all approximately the same size or really close. And then there's poikilocytosis, which is when red cells are present in various shapes. And probably the most common example of that would be sickle cell anemia, when the erythrocyte is actually completely misshapen. And that really affects how it can travel and how it can function. Okay, so physiologic manifestations of anemia are usually related to the reduced ability to carry oxygen, which we know is called hypoxemia. So it's often very mild onset. People usually don't even know they have it. It starts very gradually. So it's easy for the body to compensate or to adjust to the symptoms that the person's feeling. And so it might not warrant a visit to the doctor, because you just might not even notice unless you're doing something that's physically exerting yourself. And then you might be like, man, it was really hard to get up that flight of stairs. That was weird. But you may not automatically think, I have anemia. So there's variable symptoms, and it really is based upon the severity of the anemia and how well your body does at compensating. But these are the classic symptoms that patients come in with: fatigue, generalized weakness, dyspnea, which means shortness of breath, and pallor, which means a very pale appearing skin. That's all related typically to anemia. But as the anemia progresses or gets worse, people are going to feel symptoms much more often and significantly more severe. Okay, so this is our first vocabulary lesson. So we're going to talk about macrocytic normochromic anemias, and there's several that fall into this category. So if we look at macrocytic, remember cytic is related to the size. So we've got a macro cell, it's a big cell. And then it's normochromic, and remember chromic refers to the hemoglobin content. So we have a normal hemoglobin content in these types of anemias. So look at the words. It's going to help give you a clue as to what in the wide world they're talking about when you come across these. Another name that your book refers to these as is megaloblastic anemias, but as long as you can understand that it's a macrocytic normochromic anemia, you'll be fine. So really characterized by big fat stem cells, and they develop into big fat erythrocytes. What happens though, that's a problem, is that they're defective erythrocytes, and it impairs the ability of the cell to correctly do DNA synthesis. And it's caused by vitamin B12 or folate deficiencies. So it's vitamin B12 and folate or folic acid are essential components for a mature nucleus in a cell and also for DNA synthesis to occur. So without vitamin B12 or sufficient amounts of it or folic acid, then you run into a problem with one of these types of anemias. RNA processes can keep happening normally, but without them, the DNA synthesis doesn't occur, which is going to result in the erythrocytes dying prematurely. And that way you're going to end up with a decreased number of erythrocytes. The example we're going to talk about is pernicious anemia. It's the most common type of macrocytic anemia. And it is caused by a lack of something called intrinsic factor. Your book calls it IF. And that intrinsic factor comes from gastric parietal cells. It gets secreted. And it's essential that we have intrinsic factor in order to be able to absorb vitamin B12. So when that happens and we cannot absorb the vitamin B12, we end up with these signs and symptoms of pernicious anemia, because if we can't absorb B12, we can't do DNA synthesis. We can't have mature nuclei in the cells, basically. Okay, so again, early symptoms are very vague. Usually develops really slowly over about 20 to 30 years, to be honest. But once the hemoglobin level drops to somewhere in the 7 to 8 grams per deciliter range, so on a blood test, on a CBC, a complete blood count, you would see a hemoglobin level potentially lower than this. But once it gets to between 7 and 8, your patients are going to be pretty symptomatic. They're usually going to be pretty weak. They're feeling exhausted because remember, without erythrocytes, you can't transport oxygen because there aren't enough hemoglobin molecules to grab the O2, take it to the tissues, grab the carbon dioxide, and get it out of the body. So weakness, fatigue, paresthesias are like a tingly, sharp shooting sensation, usually in the hands and feet, but it can be other places too. Difficulty walking can happen. Patients have a loss of appetite. They're so weak and fatigued, they do not feel like eating. They can have abdominal pain, weight loss, and a sore tongue. This happens, we call it a beefy red tongue. It gets very large and swollen and almost smooth when patients have certain types of anemia, like pernicious anemia. Then you can also have neurologic manifestations. So what actually happens is the nerves demyelinate because of the lack of vitamin B12. And you can actually develop things like difficulty, well, it's the difficulty walking is listed there for you, neurocognitive disorders, depression, and it's very often seen, low B12 levels are very often seen in patients with Alzheimer's disease. So there could definitely be a link there. And the problem is that these neurologic manifestations are not reversible. So if it gets to this point, unfortunately, we can't change what's happened in terms of the demyelinization of the nerve cells. So the treatment for this is pretty simple. It's either parenteral, meaning any route besides oral, besides going through the gut. So we usually give vitamin B12 shots, or high doses orally of vitamin B12 for the rest of your life. Because if you have a problem with the gastric parietal cells secreting intrinsic factor, it's not going to get better. So we will just have to supplement the patient with very high doses of vitamin B12. But the good news is that it is treatable, and usually the patients do really well. So that's pernicious anemia. Now we're going to talk about folate deficiency anemia. So this is folic acid is an essential component for both RNA and DNA synthesis, and it typically affects rapidly dividing cells like the blood cells when we have a folate or folic acid deficiency. The good thing is that folic acid is not dependent on any other factor, like vitamin B12 requires intrinsic factor. Folic acid can just be absorbed, but we need to pay attention because we are completely dependent on our oral intake of folic acid through our diet in order to get any folic acid. The good news also is that lots of different foods are fortified with folic acid now, cereals and things like that, so that it is more readily available. And there are, supplements as well. The symptoms are really similar to pernicious anemia, except we hardly ever see neurologic manifestations in folic acid deficiency anemia. And really, we just treat it simply by giving daily doses of folic acid. It's really often seen in malnourished patients. So certainly if someone had an eating disorder or was an alcoholic, and then any other condition that results in chronic malnourishment, we see this quite a bit. But once you start giving folic acid supplements, usually all the signs and symptoms disappear within about a week to 2 weeks. So pretty easy to treat and good results. Okay, so those are the two macrocytic anemias we are going to talk about. Now we're going to move on to microcytic hypochromic anemias. So micro meaning small size, cytic is size, right? And then hypochromic, meaning hypo is low, right? Low or slow. So we have a low hemoglobin content with these anemias. So these are really small red cells that have reduced amounts of hemoglobin, and it's usually related to problems with iron metabolism, can be disorders of porphyrin or heme synthesis and globin synthesis, and we'll kind of talk about that in more detail. The other thing to keep in mind is that hypochromia can happen in cells that are normal size, so normocytic cells as well. So not always is it going to be microcytic cells. Okay, the most common type of microcytic hypochromic anemia that we're going to focus on for this class is iron deficiency anemia. Really common in the world and in the United States, certainly. So it's basically a nutritional iron deficiency or as a result of blood loss. So if somebody has been in a motor vehicle accident and experienced a significant injury where they have bled a lot, we would anticipate that they would have a hypochromic anemia. So again, usually you're going to see signs and symptoms in patients when that hemoglobin drops to within the 7 or the 8 grams per deciliter range. The people who are at highest risk for this type of anemia, for iron deficiency anemia, are typically those who live in poverty, women of childbearing age, which makes sense because they have regular blood loss, and in children, actually. So, and the problem with kids getting iron deficiency anemia is that it is associated with cognitive impairment. And those things are hard to reverse. So we really want to pay attention to children's diets, making sure they're getting appropriate amounts of iron so that they don't encounter cognitive deficits for sure. Just as a note, the causes of iron deficiency anemia can also be metabolic or functional, which is insufficient delivery of iron to the bone marrow, or impaired iron absorption once it does get into the bone marrow. So that's usually it's much more rare, and usually is being caused by some metabolic disorder, basically. So signs and symptoms I listed there for you as well. Again, fatigue, weakness, shortness of breath. So if you think about it, with decreased amount of hemoglobin, your body, remember, is going to increase your respiratory rate in order to try to pull in and attach as much oxygen as possible to the erythrocytes. So you're going to start to breathe faster to try to pull more oxygen in so it can attach to any available hemoglobin to be transported out to the tissues in the body. Pale, typically all over, but sometimes you can see really pale earlobes and palms, and conjunctiva. So that's the tissue inside the eye. When you pull the lids down, that you would see a pale conjunctiva. Normally that's like a nice pinkish color. With iron deficiency anemia, it'll be really pale. Okay, so again, progression is usually slow onset, very gradual. Your body can handle it. You don't feel symptoms early on, and then you just start to feel really tired and just like you're not yourself. Usually, as things progress and they get worse, you're going to start to see things like brittle, thin, coarsely ridged, spoon-shaped nails. So this is over quite a bit of time that you would see these kind of symptoms, but you'll actually see the nail bed itself looks like a spoon. It's very flat and almost indented, and the nail will sometimes fan up a little bit. That can be indicative of someone who's had iron deficiency anemia for a long time. Again, a red, sore, painful tongue. So it gets kind of smooth. It looks very beefy, like something you might cook in the kitchen. It's very characteristic. But this is all of these things that are listed here are basically structural and functional changes of epithelial tissue because of the lack of iron, the lack of the lack of iron, which results in decreased erythrocytes, which results in basically hypoxia to the tissues themselves. Also dry, sore corners of the mouth. So we call that angular stomatitis. It's literally right in the crack of the mouth. Can be other things as well, but lots of times can be indicative of iron deficiency anemia. Okay, so normocytic normochromic anemias. This means red cells that are normal in size and they have a normal hemoglobin content, but we just don't have enough of them. We're not going to go into a whole bunch of detail on these, but these are the 5 types of normocytic normochromic anemias. Again, normal size, normal hemoglobin content. We just don't have enough red blood cells. So in aplastic anemia, the problem is damage to the bone marrow. And this can be for several different reasons, but sometimes it can be for no reason at all. I've seen it in children. And for whatever reason, their bone marrow just stops producing cells. And then you have aplastic anemia. And the only way to treat that is to do a bone marrow transplant and give them a new functional bone marrow. You can have post-hemorrhagic anemia, which makes sense. You have acute blood loss, you have normal sized cells, you have normal hemoglobin content, you just don't have enough of them because you lost them. They bled out. You can have acquired hemolytic anemia, which is when your own body's immune system destroys the erythrocytes. You can have hereditary hemolytic anemia. These are things like sickle cell anemia, where the cells are genetically altered and essentially results in increased destruction of erythrocytes. Because they're not shaped the right way, they get destroyed more rapidly. And remember, your red blood cells should last about 120 days. So if they're breaking down sooner than that, then you're going to have lower numbers of circulating erythrocytes. And then anemia of chronic inflammation, there's lots of different causes for that. We're not going to go into that for the purposes of this class, but just take a brief look at those in your textbook so that you have a general definition of what each of those is. Okay, so we're going to move from erythrocytes now to leukocytes. So these are alterations in leukocyte function. So leukocyte function is usually affected if there's too many or too few WBCs present in the blood, or if the cells that are present are defective in any way. So we have phagocytic cells that can basically lose their ability to act as phagocytes. We have lymphocytes that can lose their ability to respond to antigens. So we're going to just talk very briefly about that. So when we have a problem in the quantity of leukocytes, so that could be either too many or too few, we want to pay attention to that. So when we see leukocytosis, we are talking about what you see when you have an elevated white blood count in the presence of something like infection. So leukocytosis refers to an increased number of leukocytes. That is what we see when we run a complete blood count and we look at the white blood cell count and it's elevated. We call that leukocytosis. And then leukopenia, we have an abnormally low number of leukocytes, and that can put us at risk for infection, because remembering that those white blood cells are a huge component of our ability to have an immune response. Okay, so we're going to talk about granulocytosis and neutrophilia. So neutrophilia is, remember, granulocytes are the neutrophils, eosinophils, basophils, right? And basically, neutrophilia is the first evidence that we have of either an infection or an inflammatory process in the body. So when we run a complete blood count, when we suspect inflammation or an infection, and we do that CBC and we look at the neutrophils, this is kind of one of the first indicators. We're going to see an increase in the neutrophil count when we have a new onset of infection or inflammation. So then if the body is requesting more neutrophils, then those immature neutrophils get released into the blood in response to that from the bone marrow. When we look at a CBC, I just want you to have had an introduction to this. This premature release is shown on a blood draw when we have that increased number of neutrophils referred to as neutrophilia. We call that a shift to the left. Just tuck this away in your memory because you're going to hear it when you're out working. So a shift to the left on the CBC with differential just means that there is a premature release of these neutrophils into circulation, which probably means there's some sort of an infection or inflammatory process going on. And then we call it a shift to the right when it goes back to kind of more of a normal ratio. Okay, and so that's in the case of infection or inflammation. We have neutrophilia. When we have neutropenia, that means we have a reduction in the number of neutrophils in circulation. So I always think of penia like teeny little, a small amount of neutrophils. This can be caused or it can be seen in diseases like aplastic anemia, like leukemia, lymphoma, myelodysplastic syndrome. There's lots of disease processes that can result in a reduction in the number of circulating neutrophils. We can also cause it to happen by giving certain types of medications that suppress the bone marrow. It can be caused, neutropenia can be caused by a long course of a severe infection. It can be caused by decreased production of cells. It can be caused by reduced survival of those cells. So if they're getting lysed for some reason, we would see neutropenia. And then we can see it when we have either abnormal distribution or sequestration. So if all of the cells for some reason are getting caught up in the spleen and destroyed, then we would see neutropenia. So again, aplastic anemia, leukemia, lymphomas, myelodysplastic syndrome, all those would present themselves as potential causes for a patient with a low circulating number of neutrophils. Okay, and then just touch base quickly because it is a lymphoproliferative clinical syndrome is what your textbook calls it. Infectious mononucleosis is very common. It's an acute self-limiting infection, which means your body will take care of it itself. There's no actual drug to give you to cure you of mono. But it's when you get an infection of B lymphocytes that are transmitted by saliva through personal contact. So they used to call it the kissing disease, but that's not actually exactly correct. You could just share a glass with someone and get mono. It's usually caused, most commonly, it's associated with the Epstein-Barr virus, like up to 85% of cases. Epstein-Barr will like kind of kick the patient into infectious mononucleosis. So and that's because B cells have an Epstein-Barr virus receptor site, so they bind really easily together. There's other viral agents that are similar to mono, which are cytomegalovirus, hepatitis, influenza, and HIV. So we have to be conscientious when we're working with these patients that we identify what's going on. But the main symptoms that you will see in infectious mononucleosis are fever, sore throat, swollen cervical lymph nodes, so that's all in this area here, increased lymphocyte count, and you're going to see atypical lymphocytes on the blood test. Serious complications are super rare. It's usually the patients just feel pretty awful, like they have a flu for a long time. And rest and hydration and symptom management are our main treatments for it. But in rare cases, splenic rupture can occur, and it's sort of spontaneous. So anytime we suspect mono or an EBV infection with patients, we always tell them that they can't do any contact sports or any vigorous activity for about a month because you could just get bumped, and it post having an infection with mono and EBV, it could cause your spleen to rupture, and that is the most common cause of death related to infectious mononucleosis. You've got to have for diagnosis greater than 50% lymphocytes and at least 10% atypical lymphocytes on a blood test. We do, for diagnosis, monospot qualitative test is the gold standard. And like I said before, the treatment really is just symptom management. So if you have a fever, take some Tylenol. If you have a sore throat, gargle warm salt water, teas, soups, those kind of things. Rest as much as possible and stay away from other folks in terms of not spreading it. So usually these guys are off of school for a while because it does typically seem to hit the adolescent age group the most. Okay, so let's touch base on leukemias. There's a lot, you could do a whole class on leukemias, but we're just going to focus briefly. So whatever is not discussed in the PowerPoint, you don't need to know the entire background of leukemia, but focus on what's here in the PowerPoint when you go back to do your reading. So leukemias are malignant disorders of the blood and the blood-forming organs. So usually the blood and the bone marrow is what we're talking about. We get uncontrolled proliferation, so uncontrolled growth of malignant leukocytes. That's why it's called leukemia. And they overcrowd the bone marrow. and it causes decreased production of healthy blood cells. So we get an excessive accumulation of leukemic cells, you can see there on the slide, and then that results in something called pancytopenia. So if neutropenia means a reduced number of white cells or neutrophils, pancytopenia, pan means everything. So every type of cell that gets produced in the bone marrow is suppressed because there are all of these leukemic cells there taking up all the space. So you're going to see, in the case of leukemia, a low white count, a low red blood cell count, a low platelet count. You're going to see all of it low because these leukemic cells are kind of taking over the factory, as it were. So in acute leukemia, you're going to have undifferentiated or immature cells, and they're usually referred to as blast cells. And so on a slide, we could take a blood sample and put some of that onto a microscope slide, and we would have the presence of blasts or blast cells in that specimen, and that would help to diagnose acute leukemia. There are also chronic leukemias, and the cell type in this is predominantly mature. It's not an immature or undifferentiated cell, but it doesn't function like it should when you have the presence of chronic leukemic cells. So there's a little bit of a differentiation there. Acute leukemia, undifferentiated, immature cells, we call them blasts. In chronic leukemia, they're usually a mature cell, but they are not functional in the way that they should be. So these are the major signs and symptoms of leukemia, which is tricky because if you look at them, it looks like a lot of different things, like fatigue, that's non-specific, right? A fever could be anything. Weight loss, again, could be lots of different things. With leukemia, because all those blood cells get suppressed, the normal healthy ones, we don't have enough platelets. And because of that, you're going to see petechiae and ecchymosis. So ecchymosis refers to bruising, whereas petechiae, I should have put a picture in here for you, but are little speckled dots of bruising. Usually appears, some common places are the face, the palate inside the mouth. You can get them anywhere. Abdomen seems to be pretty common, over the upper thighs, palms of the hands, soles of the feet. Just little purple dots, tiny little dots, and those are called petechiae. And then ecchymosis is bruising. So a lot of times parents will bring in children with unexplained bruising, and they also say, my kid won't walk anymore. And that's because of the bone pain that they're feeling. So the bone marrow itself gets so packed with these leukemic cells, it just hurts. Your bones just hurt. And so patients will experience bone pain. Weight loss is really associated with, number one, you're in a hypermetabolic state. Your body's working really hard to try to deal with this overproduction of leukemic cells. But also patients just don't feel well, and so they don't feel like eating. It's like when you have the flu and you're like, don't bring me anything, I can't eat right now, I feel terrible. Elevated uric acid levels happen because there's so much turnover and breakdown of cells. Uric acid is a component of cell breakdown, and so you're going to see those uric acid levels rise in the body. Liver, spleen, and lymph node enlargement, because cells are just getting stuck everywhere. Your body's trying to filter them out, and so those organs are going to become enlarged. You can see an increase in infections because, again, the leukocyte production is depressed. You have neutropenia, and so it opens up your body to lots of potential infections. And then you've got neurologic manifestations, again, mostly from all those waste products that occur, that potentially you can have alterations in level of consciousness and all kinds of stuff. So, okay, I think that's good for that. So when we're talking about acute leukemias, there's acute lymphocytic leukemia and there's acute myelogenous leukemia. So you have ALL and AML. And I'd like you to look at that and figure out how you can differentiate that. I'm going to tell you that in ALL, we have too many lymphoblasts. This type of leukemia typically happens in kids. And the problem is there's too many lymphoblasts. They are over proliferating and just messing up the whole system. In AML, the problem is with the myeloblasts. So that's how you differentiate between the two. There's too many myeloblasts, and it's the most common type of adult leukemia. So we see lots of ALL in kids, lots of AML in adults, and then there's a bit of a crossover that happens in there. But those are kind of generalizations. You will see bone marrow depression, signs and symptoms of fever, anorexia, or they just don't want to eat. And again, neurologic symptoms can be present. We always treat this with chemotherapy as the primary means of treatment. And ALL and AML protocols can be quite lengthy. These patients can expect at minimum 2 years of treatment. Part of that's inpatient, part of that's outpatient, but it's quite a long process. And if all goes well, though, the cure rates are excellent, and patients do very, very well with their 5-year survival rate. So lots of good news in regard to leukemia and leukemia treatment. Okay, then let's just touch base briefly on chronic leukemias. The primary one that you would see in practice are patients coming in for flare-ups of CML, but the same differentiation. So it's either a problem with the lymphoblasts or a problem with the myeloblasts. So CML is chronic myelogenous leukemia, and CLL is chronic lymphocytic leukemia. CLL is the most common adult leukemia in the world. Both of these have a really slow progression. Patients can live to a normal lifespan. They can have periods of remission and flare, so we can get it under control and they can be fine. Their blood counts will look great for years. And then they can potentially relapse. And again, that's what gives it that chronic nature. It's that long term. And typically with these, you're going to have lots of lymphadenopathy, and that's very often, that means swollen lymph nodes. That's very often their first symptom that something might be acting up again. So these patients are under surveillance continuously for the rest of their life once they're diagnosed. Okay. Figure 21.6 is a good one for looking at both acute and chronic leukemias, just to kind of see the bloodlines that they come from. You don't need to memorize that table. It's just a good reference for you. Okay, so let's talk about malignant lymphomas. So this is when we have a problem with the lymphocytes in the lymphoid system. Typically, there are two major categories. So we talk about Hodgkin lymphoma and non-Hodgkin lymphoma. There's been a new classification system that's been pretty recently developed called the REAL classification. We'll talk about that, but this is really the most common blood cancer that occurs in the United States. It is with Hodgkin lymphoma. Basically, it's a sequential progression of lymphoma that goes from one lymph node to the next lymph node to the next lymph node, like a chain reaction. And you're going to have the presence of a specialized type of B cells called Reed-Sternberg cells. So to be diagnosed with Hodgkin lymphoma, you've got to have the presence of Reed-Sternberg cells. That's what's going to differentiate it from non-Hodgkin lymphoma. And again, it's that chain-like progression from one lymph node to the next lymph node to the next lymph node to the next. In non-Hodgkin's lymphoma, it's usually non-contiguous lymph nodes, which means like you could have a lymph node here, and then you could have a lymph node underneath your left armpit, and then you could have a lymph node in your right groin. It's not going in a chain reaction. It's kind of all over the place. And there are no Reed-Sternberg cells in non-Hodgkin's lymphoma. The usual treatment for both types is going to be a combination of chemotherapy, radiation, and surgery. And now we're incorporating things like monoclonal antibody therapy to try to help the body fight off the lymphoma more on its own. So if you can hear my cat. The real classification has really just broken things down into 3 categories. So you've got Hodgkin's lymphoma, and then instead of saying non-Hodgkin's, we're focusing it on B-cell neoplasms versus T-cell neoplasms. So just tuck that away in the back of your mind in case you ever work in oncology, but we won't worry about that for the test. The outcomes for lymphoma, typically good, and pretty good prognosis depending upon the staging and things like that. Okay, then let's talk about some disorders of platelets. So thrombocytopenia. So when we're thinking about thrombus or thrombo, you can see that beginning of the word there. That's really related to our platelets. So anytime you see that, we're talking about platelets, and we're talking about a low number of platelets. So usually less than 150,000. So if you're looking on a 150 is usually how it's listed. Platelets less than 50,000 would be indicative of a huge increased risk for hemorrhage from any minor trauma. If you have a patient with platelets less than 15,000, they are at high risk for spontaneous bleeding. And less than 10,000, it's pretty dicey. You don't want that patient really moving around at all because they are so at risk for bleeding. So these are the types of patients that typically would not be able to brush their teeth with a toothbrush. They would need to do mouth rinses, and maybe they could use a little sponge, little toothette, the little tiny sponge on a stick to brush their teeth with. But otherwise, they should not be brushing their teeth. They should be really careful when they're cleaning themselves after using the bathroom because those types of tissues can bleed really easily. Anything, they could sneeze and get a severe nosebleed because they don't have any platelets. So I just want you to be familiar with the term thrombocytopenia and what that means. So the things that can cause it include hypersplenism. So that's like an overactive spleen. Autoimmune diseases, so your own body can attack its own platelets and destroy them. Hypothermia, interestingly enough, causes the platelets to break down. Viral and bacterial infections that can cause something called DIC, which we're going to talk about briefly, disseminated intravascular coagulation. So we have a problem with the clotting cascade. And then we can also cause it by giving our patients a medication called heparin, which is basically an anticoagulant. So we can give our patients, by trying to do good for them, we can cause them to have thrombocytopenia because of giving them a medication called heparin. And so when we give heparin, we've talked about IgG antibodies. We have IgG antibodies that will then target this heparin platelet factor 4 complex. Don't memorize this. Just tuck it away for later, that there is the possibility of causing someone to get thrombocytopenia by giving them heparin. And it can really drop those platelets quickly, like by half. So we've got to keep an eye on that. We've got to educate. We've got to be prepared to intervene if necessary. Okay, so this is one of the most common disorders of platelets that we see in patients, certainly in the clinic setting, and sometimes we'll see them in inpatient if they're, especially if they're getting newly diagnosed. So immune, idiopathic, those words are used interchangeably. Thrombocytopenic purpura, and so people will refer to this as ITP. I have ITP. So there's an IgG antibody that develops, and it targets, unfortunately, our platelet glycoproteins. And so basically it causes an antibody to coat the platelet. Our body's own surveillance system will then grab those platelets, pull them out of circulation, and destroy them. So our own body is destroying its platelets, which is causing us to be at a really increased risk for bleeding. It can happen after viral infections, especially in children. And it's just one of those things where the virus itself induces the antibody response, and then the body just goes after We talked about how that happens sometimes in the heart valves after like rheumatic fever, but in this case, the body is targeting its own platelets. So we're going to see again petechiae and purpura, which are those tiny little bruises, those little purple kind of dots all over. And it can progress though even to major hemorrhage. So we need to treat it and be focused on managing that. So the way we do that is through IVIG infusions. So that's the IV immunoglobulin infusions to give the patient passive immunity, essentially to tell the body, knock it off. This is self. You shouldn't destroy it. The problem with that is it's short-lived, and these patients usually have to go monthly for infusions of IVIG. But it's treatable, which is great. Okay, so essential thrombocythemia. This is when you have a really high platelet count. So we just talked about the problem with low platelet count. This is high platelet count, greater than 400,000. And the problem with this is that it makes our blood kind of sludgy. It's like motor oil instead of the liquid that it should be. And so in this case, there's a problem that megakaryocytes in the bone marrow are produced. There's too many of them. It's just producing. And remember, those megakaryocytes are those big fat cells with a whole bunch of DNA in the middle, and then they fragment into all the platelets. So there's too many of them. And what happens is we get tiny little clots all over in all of the vasculature in our body, and or it can ultimately result in hemorrhage that can happen because there's too much going on. The blood's too thick and sludgy. It blocks up all the little tiny vessels in the body. We get blood clots, and then everything falls apart from there. Let's see. Okay, so anytime we have a change in the platelet function, we can have different manifestations, but they're usually really similar. So if the platelets are not working effectively for whatever reason, we are going to see those petechiae, so those little purple dotted bruises, purpura as well, also bruising. You can have mucosal bleeding, which can be any mucosal surface. So that could be the mucosa of the GI tract, even in the respiratory tract. So a patient could cough hard and start bleeding in the mucosal lining of the respiratory tract. And gingival bleeding refers to the gums. These disorders can be congenital or they can be acquired. Sometimes it happens, like we talked about, like post-viral infection. But it is something that we need to pay close attention to. And then in addition to that, we can have problems with coagulation. So this is our ability to clot. The couple of things I just want to touch on with that are vitamin K deficiency. And be real careful that you don't confuse vitamin K with the abbreviation for potassium, which is K+. So vitamin K is just that, it's vitamin K. We need it to be able to make, synthesize, regulate prothrombin and all of our clotting factors. I don't need you to memorize this. I just need you to know that vitamin K is necessary for the coagulation cascade. The other thing is, and sometimes we have deficiencies in vitamin K for a bunch of different reasons, but primarily we want to make sure that we're following our patients and figuring out why are they bleeding, what's going on, do they have a deficiency, or is it some kind of an autoimmune thing, or what's happening. Liver disease is also a contributor to alterations in coagulation because the liver is primarily responsible for, what am I trying to say, for the clotting cascade, and without the liver, we wouldn't be able to clot. So when we have liver disease, then we get a defective ability to coagulate. We have a problem with fibrinolysis, and we have a problem with platelet number and function. So We want to be aware that any of our patients that have liver disease, we need to pay attention to their risk for bleeding. And then this is not going to be on your exam, but I wanted to introduce you to DIC, or disseminated intravascular coagulation. Um, I'm just going to let you read through this, and we can definitely talk about it in more detail if it interests you. But this is something you need to tuck away for future reference, because especially in your patients in the ICU or who have had like a traumatic injury or something, this is a very real possibility, and it typically results in death. So what happens is, basically, it's a really complicated cascade that happens where the body starts clotting rapidly, and it uses up all of its clotting factors really fast. So there's no possibility of replenishing them quickly enough. And then they start to hemorrhage at the same time. So they're clotting all over the place. There's clots everywhere, but they're still bleeding out because they can't synthesize clotting factors. Well, they've used them all up, so they can't make any more fast enough. So that I put possible cause here. It's a little bit still unknown as to why that happens, but there's increased protease activity in the blood. We get unregulated release of thrombin with fibrin formation, and you get all kinds of fibrinolysis, because once you start to form a clot, the body starts to break it down, and it's just this big snowball effect that happens. So usually it's related to significant endothelial tissue damage that starts it off. And most commonly, these are in your patients that have severe gram-negative sepsis. So this is gram-negative bacteria, which we've talked about, and it's taken over basically the bloodstream, the whole body. So this is most often when we see DIC happen. So you can just read through this. Feel free to shoot me over some questions if you're interested in it, and we'll kind of go in more detail. It will not be on your exam, but I did want you to have some information available to you for future as you head into your nursing careers. So these are your patients clinically that you're going to see just oozing blood from everywhere. So anywhere that there's an opening in their skin, they're going to just be leaking blood. It'll come out their eyes, it'll come out their ears, it'll come out wherever they've got an IV or a tube stuck in them. So it's pretty significant. And you will see cyanosis of the fingers and the toes, and it's very creepy because it'll start from the tips and you'll just see everything turn blue, and it'll move up symmetrically both sides, hands and feet. So it's pretty kind of horror movie status, but fascinating. So let me know if you have more questions. We're going to stop there today, and I hope you all have a fantastic week, and I look forward to seeing you all soon. Thank you guys. Have a good night.